Good afternoon and good morning to those on the West Coast. Thank you for joining the Healthcare Executive Group's webinar series. Today's webinar, Don't Miss the Boat, ICHRA Puts the Consumer First, is presented by Softeon, a longtime gold sponsor of HCEG. I'm Justin Petrignani, National Account Executive at Softeon. We're all looking forward to an informative webinar and we appreciate your interest and engagement. Before we start the webinar, just a few housekeeping items. All attendees are on mute. However, we welcome and encourage questions and attendee interaction. Please feel free to submit any questions you may have on today's material in the webinar dashboard, and we'll try our best to address them during the webinar. If we can't get to your questions, we'll reach out afterwards. Today, we have two esteemed panelists joining us for the webinar. Kevin Deutsch, GM and SVP of the Health Plan Cloud of Softeon. Kevin is responsible for Softeon's Health Plan Cloud, from operations and product development to consumer satisfaction and growth. Kevin works with issuers across the country to support their goals and mission. Previously serving in client success, Kevin has developed significant industry experience through some of Softeon's large implementations and client relationship management. He received a dual bachelor's degree in mathematics and computer science from St. Joseph's College at Patchogue, New York, and is currently enrolled in an executive leadership program through Cornell University. We also have Ferris Taylor joining us. Ferris is the executive director of the Healthcare Executive Group, a national network of thought leaders focused on innovation and technology to grow, share, and reshape healthcare. Prior to becoming executive director, Taylor served as a board chair of HCEG and as the chief operating officer and chief strategy officer of Arches Health Plan in Utah. Earlier, Taylor founded Pragmatic Healthcare Solutions, a healthcare strategy and marketing positioning firm, and has served as VP of Payer Market Strategy at Optum and VP of Marketing and Planning at Partners Healthcare's North Shore Medical Group, and head of Marketing Information Services at Harvard Pilgrim Healthcare. With that, it's my pleasure to hand the mic over to Ferris Taylor.
Thank you, Justin, and thanks to Softeon for your many years as a technology partner and sponsor of HCEG. Kevin and I plan today to discuss the fairly recent healthcare policy changes with respect to using the ACA individual markets and HRA accounts, standing for health reimbursement arrangements, to help more employees and consumers have access to insurance. We will share some of what ICHRA, the short part of these individual coverage HRA accounts or arrangements, is all about, how it's different from past programs, and why it could be important to many of you and your customers. We'll also talk about what ideal solutions might look like and some of the challenges you might encounter implementing them. This will be an open discussion, so as Justin has said, submit your questions in the box as they come to mind. And we did receive from some of you questions in advance of the webinar, so we're excited about discussing some of those. We are planning follow-on webinars on ICHRA over the next few months, so your questions will help us put those webinars together. And of course, we will be sharing the presentation materials and recording of the webinar following this discussion for your future reference. As background, HCEG is a national network of executives and industry leaders celebrating our 32nd year working together to improve and reshape healthcare. We interact regularly across multiple channels such as these monthly webinars, periodic roundtables, white papers, digital media, newsletters. We do a national industry pulse research, which you may have seen recently, and we have an annual forum each September. By facilitating these frequent interactions, we provide a platform for networking and thought leadership around critical issues, and this is one of them. Throughout that year, each year, and culminating in our annual forum, our members discuss and debate a wide variety of critical issues. We then formally vote and rank what we call an HCEG Top 10 set of priorities for the coming year. Each of these 2020 HCEG Top 10 are important, but today's webinar will focus specifically on priority number 9, which you see down there at the bottom, healthcare policy. But ICHRA also touches on several other critical HCEG Top 10 issues, including but not limited to the very first one, cost and transparency, and even more importantly, with respect to ICHRA, number 2, with respect to consumer experience in healthcare. For more insights on all the HCEG Top 10 issues and access to prior year's lists and the National Industry Pulse Research, you can visit our website at hceg.org. which is there in the bottom. So with that quick background on HCG and the top 10, let's get started on ICHRA. Kevin, we've had qualified small employer HRAs, or QSERAs, since the 21st Century Cures Act in late 2016. What is ICHRA, and how is it different from QSERA, and how might it impact those on the phone and many others in our country?
Thank you, Ferris, and thank you to the Healthcare Executive Group for spending so much time to put this together, and also to those of you who are attending. This is something that we're really excited about and look forward to digging into some great detail here. So starting with, what is ICHRA? ICHRA stands for Individual Coverage Health Reimbursement Arrangement, and this is really the evolution of the QSERA, which we'll talk about here in just a moment. But some of the key highlights of ICHRA is related to, this is a true defined contribution. This is where the employers are able to allocate specific funds for individual employees to reimburse them for qualified health expenditures. Some of the different aspects of this includes that this is open to employers of all sizes. So it's not specific to small group or large group. Employers of any size can participate in ICHRAs and allocate funds towards their employees. One of the other main attributes of ICHRA is that it allows employees to enroll in individual health plans. So as opposed to the employer-defined plans, individuals were able to go out and enroll in their own health plans. And one of the other main components of the ICHRA is the fact that there is truly consumer choice, and we'll dig into this quite a bit over the next hour or so. But basically, the consumer has the option to either go the ICHRA route based on what their employer defined for them, or elect an advanced premium tax credit or APTC. And like I said, we'll dig into this in quite a bit of detail. At the bottom of the screen, you'll see a timeline of everything has happened rather quickly, with the final rule being released in June, and it was effective for plan year starting January 1 of 2020. So this is currently live in production. This is not something that is a future development. This is something that is here, and it's happening very quickly. To continue on and to really set the stage, we wanted to take a look at some of the numbers and to set some background and context for you. And you'll see that it wasn't a mistake. There are truly 800,000 in both of those boxes there. The first one being the uninsured population, who will now be able to obtain healthcare coverage. And these are through employees of employers that cannot currently afford to offer health insurance that will now be able to. And that goes to that second box of the 800,000 employers are now able to join this market and allow their members to get that individual coverage, as I mentioned. One of the two bigger numbers on the right-hand side there, one is related to the CMS projection that in the next 10 years, there's 11 million new entrants that are expected into the individual market as a result of the individual coverage health reimbursement arrangements. And there are 160 million employees as the overall total addressable market that could end up jumping in and getting involved with individual health plans. Continuing down the path, and everything that we do here is centered around the consumer journey. So we wanted to take you through what it looks like as a consumer for both the employer aspect and the employee aspect of an ICHRA. Starting off on the employer side, the employer will establish different classes, and there's 11 different classes that the employer can choose from to segregate their employees, and they'll define the reimbursement amounts for each of those classes of employees, if you will. From there, the employees will be responsible to go out and shop for their individual health insurance coverage, at which point they would submit documentation to their employer to be reimbursed for the funds that they put towards their qualified health expenditures. And lastly, in the flow is the employer will reimburse the employee for those expenses. And we'll talk about some of the potential opportunities and challenges with this specific flow. And continuing on, really to address part of your question, Ferris, related to the ICHRA versus the QSERA, there's a few different categories we'll talk about here. As I mentioned, the ICHRA stands for Individual Coverage Health Reimbursement Arrangement, whereby the QSERA was the Qualified Small Employer Health Reimbursement Arrangement. The biggest differentiator up front is the number of employees. As I mentioned earlier, on the ICHRA side, there is no specific limit on the number of employees that you have in order to be eligible to offer an ICHRA. As far as the QSERA side, you must be a small employer that has less than 50 employees. Related to the plan options, on the ICHRA side, depending on the employee class, the employer can either choose to offer the group employer-sponsored coverage or the individual coverage, where, as I mentioned, the individuals would go out and purchase their own insurance. As far as the APTC or HRA is concerned, and we put the check marks there on the ones that are clear differentiators. I think between the APTC or HRA, there's really no clear favorable option between the ICHRA or the QSERA. You can either get with the ICHRA an APTC or an HRA. In the QSERA, the APTC is reduced by the HRA contribution, so it's more a combination of both. So that it's a little bit tricky in a sense, but the ICHRA is the option where you can get one or the other, where the QSERA is you're bound to both of them. And lastly, in the employer contribution restrictions, and this is a big one with the rising cost of premiums, and we'll talk about those numbers in just a bit. On the ICHRA side, there is no limit to the contribution that you can offer to your employees, whereby the QSERA has limits for both the self-only policies and the family policies, making these plans somewhat unaffordable. And that's where some of the solutions come in.
Appreciate that, Kevin. And clearly on the QSERA, where I saw some numbers that the average family premium was $20,000, and clearly the QSERA was quite limiting on the affordability for consumers. So from a personal point of view, I've been to Stony Brook, to your offices out on Long Island multiple times, and appreciate the innovative culture that you've created at Softeon. So the next question is, why are these ICHRAs such an important topic for you personally and for Softeon as a company?
Yeah, it's a great question, Ferris. And this is our team. We pride ourselves every single day, as you can see by our mission, to make healthcare affordable, accessible, and plentiful. And this rule related to ICHRA really checks all of the boxes in furthering that mission. I know that for me, as an individual with quite a bit of experience in healthcare now, the system is very, very convoluted and difficult to navigate. And I feel that with the introduction of ICHRAs, it really allows the consumer to make their own decisions about their healthcare. And the team that we have in Long Island, New York, and Stony Brook is dedicated every single day to making this mission a reality, partnering with our health plan partners as well as government agencies and working with consumers directly. So that's really why this is so important to us and the work that we do with our platform. To give a little bit more context, as I mentioned, the intersection of the affordable aspect, accessible and plentiful, why we feel that these align with the Softeon mission is, from an affordable perspective, the consumer is not pigeonholed into 2 or 3 or even 1 plan that their employer designates for them. They can go out and choose what is the most affordable option for them, be it getting the APTC, taking the HRA, or going out and shopping for things that meet their needs, whether that be a high deductible health plan, a gold, silver, bronze, whatever makes the most sense for them, they'll be able to do that. As far as the accessibility, as we mentioned a couple of slides ago, there is a challenge with folks being able to go out and get their health insurance coverage. Their employers simply cannot afford it, which then in turn impacts negatively the employee. With the ICHRAs, whether it's $5, $50, $100 a month, the employer will be able to offer those ICHRAs out to the individuals who then can go and get access to the care that they deserve. And as far as the coverage being plentiful, by going out and shopping for your insurance, you have an increased variety of the plans that are available to you that will be able to make more informed decisions on your healthcare and truly be engaged in the overall experience. So as far as Softheon is concerned, this is something that we are super excited about, and we'll talk a little bit about some solutions here shortly, but we are very dedicated to figuring out how to solve this problem and to make healthcare affordable, accessible, and plentiful.
Thank you, Kevin. And that picture that you shared of your Softheon team in front of the Stony Brook University and where you're located definitely drives home the importance of affordability, accessibility, and plentifulness for that group of people, and actually for all of us in the country. There's a lot of creative minds being focused on this as Softheon. So, you know, as we've set up this discussion, how big of an opportunity, how big is the market for ICHRAs? Is it, and what are some of the challenges and the opportunities that need to be addressed that haven't already been solved with CUSERAs and individual health plans and all of the government programs that have come our way over the last few years?
And Ferris, it's tough to say that there aren't challenges. I know that the choice word here is opportunity, but there are certainly challenges to be addressed. And we wanted to put some more numbers in front of the group here about what the true impact is to these ICHRAs. So starting at the top, the 6% increase in employer-sponsored health plan premiums, this is a challenge. And the increase in premiums for these employer-sponsored plans are far outweighing the increases in salary for these same employees. So challenge number one is every year the gap becomes greater and greater with the affordability of their coverage that they're being offered and the ability to actually pay for and maintain that specific coverage. In addition, you can see that the average premium for a family plan in 2019 is just over $20,000 for the year. So this is not something that is inexpensive. This is something that half of your salary could go towards paying for your health insurance, and it really is not sustainable. As far as the options offered, this one to me is pretty staggering, is that the options for organizations with less than 200 employees, 81% have only one plan option. Now, who's to say that that plan option is going to meet the needs of John Doe and Jane Smith at the same time? And I think that's one of the biggest challenges that ICHRA is able to solve for, is the different variation of plans. And then the amount of coverage offered, you could see the small percentage that actually do offer insurance in that 3 to 9 employee group. So those very small employers are oftentimes not offering insurance to their employees for a variety of reasons, from administrative burden to the costs associated with it. There are many, many different challenges that are met with opportunity here with the ICHRA. Looking at some of the benefits and what this means for the employer and the employee, and that's really where we want to focus a lot of our attention for this conversation, because that's really the rule is based upon offering value to the employer and the employee. Starting off with the employer, one of the biggest things that you hear over and over again is, I need to focus on my business. I'm not in the business of healthcare. There's people and there's tools and platforms that are made for healthcare, but employers are not in that business. So the benefit of the ICHRA is that they will have tools where administratively they are very much more hands-off as opposed to hands-on with building plans and managing it on a month-by-month basis. In addition, we talk about the defined contribution amounts. Oftentimes in the landscape that we have today, there's quite a bit of variability in the month-to-month expenses for the employer related to healthcare. With these defined contributions, you set an amount per class, and that's what it's going to be month over month. There's really no variability. Another major benefit is the compliance with the employer mandate. By offering an ICHRA, you are compliant with your requirement to offer that insurance coverage for your employees, so that checks another box there. And then accessibility. As you saw in the slide prior, there's quite a bit of challenges with the amount of plans that these employers are offering. With ICHRA, it opens the world to a whole new opportunity for their employees. Shifting gears a bit and looking at the employee directly, by offering ICHRAs, the employee has access to the entire book of marketplace plans. Now, depending on the certain arrangement, whether it's a WBE or it's going out to healthcare.gov directly or to a private exchange, the employee has access to plans that they may have never been made aware of in the past. In addition, these specific plans, they don't have to fall within the standard open enrollment period from November 1st to December 15th. These do qualify for a special enrollment period, and CMS is actually currently working on creating that new SEP reason code for the ICHRAs in particular. A major differentiator and benefit for the ICHRA is the ability for the employee to truly be engaged in their health plan. Oftentimes, when you have the employer-sponsored coverage, you're working on your insurance through your employer and not really engaging with your health plan. With ICHRAs, the employees will be able to be truly engaged with their health plan, and their plan can be portable from employer to employer. So with the number of job changes that we're seeing in this gig economy, there is absolutely an opportunity here for the employees to be more engaged with their health plans due to the fact that they're not wed to their specific employer to be engaged with that health plan. And lastly, for the employee, they can make decisions based on their personal financial standing. They don't have to be dictated how much their monthly premium is going to be, whether they have to take the HRA. They have the choice to go out and do what's best for them, be it the APTC, be it the ICHRA, so on and so forth. As you can see, there's quite a bit of benefit for both the employer and the employee with the introduction of ICHRA.
Thank you, Kevin. And you know, I have to admit, and maybe many on the webinar are in the shoes that I am sitting in myself, but there's been so much emphasis around the individual market and the enrollment in the individual market, but that market seems to have stabilized quite a bit, and this seems to be taking advantage of that stability, but offering, as you're saying here, the individual the ability to find a plan that works for them. I remember sitting in an office next to a good friend and colleague of mine when I was at Optum, and I was focused on our kids getting out of college and the grandkids coming along, and his whole focus for his health plan with his 4 children was pediatrics, and without going in a lot of detail, I was focused more on geriatrics. So being able to choose the network and the benefit design that would be most advantageous to me as an individual, even though I was working for a very large company, could have been a real advantage. So that flexibility and that choice, and the fact that and you'll probably get into it, but the fact that many companies have seasonal workers or part-time workers, and they have no insurance. And you might, as we go along, talk about that as a class of employees that now can get some help from their employer, and also be able, when they go to the next job, to be able to focus on that as well. So a lot of benefits and opportunities, as you said here, Kevin. If you could paint a picture of what it would take to support both these columns, the employer and the employee, as they navigate these ICHRAs and individual insurance markets, what does the ideal solution look like?
And I'll even take it one step further, Ferris, and talk about the benefit and the solution for the health plans and the brokers as well, because there are many stakeholders involved in this ICHRA implementation. And I know we're focusing a lot of our attention on the employer and the employee as the most directly impacted, but we'd be remiss if we weren't talking about the health plan and the brokers as well. So starting off with the employer and the employee, well, what does the solution look like? And these are conversations that we're having on a daily basis to actually build this solution. But a lot of it's revolved around technology enablement and being able to offer tools for both the employer and the employee to engage in this ICHRA platform and to help make decisions on their behalf. For example, on the employer side, the way we envision the solution is the employer goes out to a platform and they determine their classes of their employees and they put in their defined contributions. Now, what this would do would then trigger an event to go out to their employees stating that their employer had enrolled in this individual coverage health reimbursement arrangement, and the employees would then have the opportunity to go out and shop for their individual insurance. One of the other aspects of this, when you dig deeper, is the ability for the employer to have automatic contribution payments made. We talk about this being a reimbursement, and we'll dig into this a bit further, but the goal is to limit the number of transactions that are going back and forth and allow for solutions that the employer can have almost immediate feedback on the actions that they're taking. In addition to that, the tool that we'd expect for an employer is the ability to make self-serve updates to the different classes, whether there's employees that are being terminated or employees that are being added. This platform would be able to service the employees. When you shift over and look at the employee aspect, this is what's most near and dear to me, as we have solutions today to do the subsidy calculation and through even enhanced direct enrollment, the ability to assign a subsidy to members on the spot on our health plan branded platforms. But what this would allow is decision support tools that, depending on the employee class and your defined contribution from the employer, you'd be able to see what's more beneficial for you. Is it the ICHRA or the APTC? And what it would also do is determine the quote unquote affordability, which is a requirement that if you were to dismiss the ICHRA or go the APTC route, the plan has to be deemed as unaffordable. So that is one thing that the decision support tool would do for the employee aspect. The other major aspect of this is the end-to-end enrollment through one singular platform. Where this could get really tricky is if there's a whole bunch of players involved. You don't want the consumer bouncing around from solution to solution. It's absolutely critical that the consumer has a streamlined flow where they can start their shopping experience, conduct their decision support, and ultimately enroll in the plan of their choosing, be it APTC through enhanced direct enrollment and other means that CMS has made available, or through these ICHRA plans with that defined contribution. Similar concept with the employer. The automatic reimbursements is a critical component to this, and one of the major barriers, which I believe we'll be talking about here shortly, is that you don't want this money to be sitting in limbo for long extended periods of time. We need this to be almost in real time, where that employee is getting reimbursed for the payments that they are fronting, and we'll dig into that in quite a bit. And lastly is the seamless transition between health plans. As we mentioned, one of the benefits is the portability. Well, there needs to be a solution to help facilitate that member or employee moving from health plan to health plan. For the health plan perspective, you'd hope that you retain those members, but in the event that you don't, or there's members that are looking to move to your health plan, there needs to be a solution to help manage those transitions. Looking at the health plan and the broker side, what do the tools look like for them? Well, for the health plan side, everything we just spoke about for employers and employees, we'd want to offer that solution to health plans, from getting their existing employers set up with these defined contributions, and then encouraging, while not mandating, encouraging their employees to stay with the existing health plan. What our expectation is that we're building a solution to support the health plans to help facilitate those transactions. As we mentioned, the payment and the HRA integration. What we want to do is have the employer and the employee able to engage in this singular platform, from the plan shopping to the employee making their payment and that getting transferred over to the health plan, to the actual administration of the HRA funds from the employer getting reimbursed back to the individual employee. So those are some of the things that we've talked about on the health plan side, with the ability to integrate with private exchanges as well. And if I was a health plan, what I'd be thinking about is, how do I get my plan front and center on some of these private exchanges where there may be significant increased traffic as a result of some of the work that's being done here. As far as a broker is concerned, similar to the health plan side, you want to build those strategic partnerships with specific private exchanges that are going to have that increased volume. And what you'd want as a broker is the most simplified solution possible for you to enroll your employees into their health plan. So I think the biggest thing on the broker side is simplicity, as opposed to working on creating plans that make the most sense. You can focus on these plans that are already available to them. So that's some of the things that we're thinking about from a broker perspective. But as you can see here, there are many, many different players involved, and it's critical that there is a cohesive solution that is built to prevent some of the potential confusion and pain points.
Very interesting, Kevin. And what's going through my mind right at the moment is, as we talk about the interplay between the four key stakeholders that you have identified here, and I'm sure there's others. See some questions coming around with respect to that. But healthcare organizations, healthcare stakeholders, as I've worked for over 30 years in the industry, are kind of, or I could say very risk adverse and often slow to adopt to new things. It's been going on 6 years getting the individual market and small group market exchanges up and function. So while it seems like we have a logical solution here for more consumer access to health insurance, the consumers, employees that haven't had access to health insurance through their employers in the past, take us through what some of the barriers are that might impede the progress with ICHRA adoption.
Well, I think the biggest thing, Ferris, as I mentioned, is the number of different stakeholders involved. We may end up in a situation, as we often see in healthcare, where everybody points at each other to be the first one to move, and then nobody moves. So along the lines of who owns the solution, that's really the question. Who's the one that's really going to push this? And I like to think that organizations like Softheon and other technology partners will be the ones to really push this forward. But we may get into a stalemate where everybody points at each other and nobody really takes action. So I think the first barrier to adoption is nobody stepping in and really being excited about moving this forward. I think when you look at the consumer aspect, the affordability measure is a little bit of a concern. And I won't go into the specifics of the calculation that determines what's affordable and what's not. But what you don't want is for the consumer to be locked into their HRA because of the fact that it was not deemed to be unaffordable. So one of the potential barriers is consumer frustration in the event that the affordability measure is not truly putting the consumer's best interest front and center. The next point, as we will not hide from, is the political landscape. There has been a sense of stability and flux all at the same time related to the Affordable Care Act and pretty much everything in healthcare. You hear about the Medicare for All concept, you hear about public options. There's many different thoughts that are swirling in the world of politics that, depending on how the election goes in November, that may very much impact what we're seeing with the ICHRA adoption, because things could, as we've seen, change very, very quickly from a political perspective, and then very, very slowly in healthcare. So it's something to really keep a close eye on as a potential barrier and challenge to move this forward. In addition, there's some variations to ICHRA that I won't go into too much detail here, but from the cafeteria plans to accepted benefit HRAs or EB HRAs, there are many different variations to the original ICHRA rule, which may cause ultimate confusion and analysis paralysis. So whereby you may want to push the ICHRA solution, there may be other solutions out there that may cloud what we're doing with the ICHRAs, for better or for worse. I'm not favoring one way or another, but I think the point is that there is an opportunity where things could get very confusing for the consumer, for the employer, for the health plan, and everybody gets into that frozen state. One of the larger areas of concern is the ability for the consumer to front their premium payments. If you think about it, if a consumer enrolls into a plan that has a $1,000 premium, for example, and they're unable to make that $1,000 payment up front, you may see quite a bit of challenges and pushback with the adoption of getting involved in this type of program. So when we talked earlier about the criticality of building a solution that will offer the consumers the ability to make these transactions happen as close to real time as possible, that's a critical differentiator, because as a reimbursement, this may put a significant strain on the individual consumer. And I know that this was talked about. I was at a conference a couple of weeks ago at CMS where this concern did come up, and there really is no concrete solution at this point with reimbursement versus payment upfront. And lastly, the barrier to adoption is that solutions are still being built. I know that we're very far down the path at this point with the solutioning for this, but there is still a lot of vetting to be done. I'm sure there will be questions that go back out to CMS related to these policies. As I mentioned earlier, the SEP codes are still being developed. So there's quite a bit that still needs to be done. That is always a barrier with the short window leading into the next open enrollment window.
Well, thank you, Kevin. And I next time we do the webinar, I think we need to turn on the polling function and ask the participants in the webinar who they think should move first to make this happen. The thought that was going through my mind as you were taking us through these barriers was that we're seeing a lot of employers stepping up with some very creative ideas. Of course, we have the Haven initiative, which was the Amazon, Berkshire Hathaway, JP Morgan, putting 1 million members or employees together and starting to think creatively about healthcare. And I suspect that some of those 3 companies have employees that currently are outside of the healthcare system that could benefit quite significantly. So I appreciate your openness and frankness about some of these barriers. We've covered a lot. We're coming up on 40 minutes on the webinar, and we did want to leave time for questions that I've seen coming in. But to sort of wrap this up, Kevin, where do we go from here? What's next for the success of ICHRA?
Yeah, and we've thought about this quite a bit, and you're seeing a lot more publicity while this topic is still very much in the background. And if you saw some of my posts earlier, it's really making some significant waves. So then the first question becomes, who moves first? As I mentioned, as a barrier, this is also the next step, right? Is somebody needs to jump in and start offering these solutions. And then of course we need to get the health plans on board, the broker community on board, and the more important is getting the employers to get excited about this. So early adoption is certainly a next step. In addition, everyone has a decision to make specifically on the health plan side, do you build this on your end? Do you build the support for ICHRA versus APTC, or do you buy a solution and work with a technology partner? Are there other technology partners and folks that may arise from some of the things that are happening here? As far as the implementation of these solutions, as I mentioned earlier, and we talked about the solution, if you have multiple different vendors that are communicating with one another and require integration in order to support this solution, that could be a major challenge, and it may take some lead time. So just some things to think about here is, what will your strategy be with integrating all of these different solutions, or choosing one partner or building it yourself so that you don't have all of these different potential touch points? And that goes for everybody from the health plan side to the employer-employee organizations and then the brokers directly. And I think my last point here is, I think a lot of us, especially at Softheon, are marching towards open enrollment 21. It seems like the moment you close the door on one open enrollment, you're already thinking about the next. So while this program is not specific to open enrollment in particular, I know that our solution, and I'm sure others out there, are really marching towards that November 1st to make sure that everything is in place and ready to start enrolling folks. So I truly appreciated the questions, Ferris, and I hope that this was in alignment with what everyone was expecting to get out of the session.
Well, and as we all experience, sometimes when you start peeling an onion, there's more questions that are underneath it, and I think your insights and your advice and your encouragement, especially this last one, to now's the time to get moving. Employers are making their decisions now and over the next few months with respect to 2021. It is time to really start looking at this in detail. And I think, Justin, I've seen quite a few questions coming across the screen here, and hopefully you've been able to organize them a little bit. Kevin, I'll let you take the majority of the lead because you had the expertise on ICHRA and what's different there. But why don't you toss some questions our direction, Justin, over the next few minutes, and let's hear from all of you on the webinar today what your questions are as well. Thanks.
Thank you, Ferris. We did have a couple questions come in. The first one I think we'd like to address is, with the complexity of our current healthcare system, how do HRAs simplify healthcare for the employee specifically?
Well, I think I touched on this a little bit earlier. As somebody who's involved in healthcare every single day, my own personal experience is still very challenging. And I think a lot of that has to do with, you're stuck with the tools that you were originally provided. So whatever your employer is offering as a tool to enroll and manage your health insurance, that's what you're stuck with. I think what ICHRA does, one, from an affordability perspective, being able to make a choice between the ICHRA or the APTC, that's really one aspect of it. But the other aspect is getting access to all of these health plans, these individual health plans that are going to be tailored more towards your specific needs. And with some of these tools that we're building on our side and other tools that'll become available, I know CMS is working on a decision support tool as well. That's going to make all the difference in this solution. We need the ability to have this process be as simplified as possible. And that's something that we're working towards every day at Softheon. And sometimes we're bound by the limits of what CMS requires. But the ultimate goal is to put this into human terms as opposed to these very technical, difficult healthcare terms that often get very confusing to the individual. So to answer the question more directly, I think that there are some challenges that could cause this to get very complicated, but I think there's hope that there's a solution that is going to be put out there that simplifies the consumer experience and really, truly, once and for all, puts the consumer first.
And I'd add to that, Kevin and Justin, and to the individual that asked the question, the thing that struck me the most as I started getting exposure to ICHRA and the opportunity that was there, well, first of all, I was almost incredulous that that somehow regulations had come together that would allow this simplification to take place. The reason I'm saying simplification is it's not necessarily something new. It's actually building on a couple of things that the consumer, the marketplace in general, has good exposure to. HRAs, health reimbursement arrangements and accounts and like that have been out there for some time. And many of us have interacted with them. We haven't used them for this application, but that part has been there. We're kind of familiar with it. And the other part that has some familiarity now is the individual market. And it doesn't matter if those of us that are on the webinar have employer insurance and we haven't had to personally go on to the individual market, but I know in my case, I have a daughter and son-in-law that have a retail store, and you know, their employees are all part-time employees. They've struggled with, how do I attract and retain these part-time employees in the retail store that don't have insurance? One of them was up skiing. I'm based in Salt Lake City, and was up skiing at one of the resorts and tore his ACL. And guess what? He doesn't have any insurance. What are the implications of that? So the individual market is the other component of this that has been out there for some time. 6 years now. It has some stability. It has some familiarity. I sat down with my daughter last fall, and we looked at all the plan options that she had, and her and her husband and her 2 kids, and which deductible, and we went through the APTC calculations to see if there was any help there. There's these components, Kevin and Justin, and for you on the webinar, that this is building on, which I hope will help address some of that complexity that obviously we need to be concerned about.
Absolutely, Ferris.
So we had another one come in. Could the ICHRA offer issuers new opportunities in small group exchanges that not exist previously, and subsequently with large group as well? Does the same apply?
Yeah, that's a great question. And I think that the implications of ICHRA to both small and large group are certainly there. And I think that if I was a health plan, I would be excited about the opportunity to convert these employer groups. One, convert new employers that you haven't seen before because they simply have been unable to offer health insurance to their employees. But 2, converting your existing groups into individuals. And as I mentioned earlier, you could truly engage with those individuals by building these platforms to support their needs. So I think to answer the question, there is an absolute opportunity for the health plans to build upon their existing small group business by enrolling those individuals, those employees into individual plans. And I think that there's an opportunity for plans to get involved in small employers that they haven't seen before, such as that 3 to 9 employee group. And if you get enough of those, it adds up. And some of the metrics we shared earlier, there's expected to be 11 million new entrants into the individual market. So while it might not look like small group anymore, it's that same membership and more that could be added to the health plans, where the health plans can really focus on that individual market and building an experience. And this is something that we didn't talk about earlier, but the health plan really has the opportunity to have these individuals engaged from birth all the way to their sunset years, where they could get them enrolled in a marketplace plan early on and transition them into Medicare Advantage. And you're seeing Medicare Advantage become more and more popular in the industry due to the aging population and the ability to offer more to the Medicare population in general. So I think from a small group perspective, there's a tremendous amount of opportunity. And don't be surprised if there's adoption at the large group side as well. The biggest thing that we talked about was that administrative burden. And with the introduction of ICHRAs, there's a lot less that needs to be done on the employer side to better manage this healthcare. So I would not be surprised if you see large groups start to jump in, and then that'll continue to expand the ability for health plans to engage with their individuals. I don't know, Ferris, if you had anything to add to that.
What was going through my mind, Kevin, is this question alone could be sort of the setup for the next webinar, because I'm based in Utah. If you recall, prior to the Affordable Care Act, Utah and Massachusetts were the two states that already had exchanges functioning. They were very different. I lived in Massachusetts for 30 years, and that was an individual exchange. Utah had a small group exchange. Interestingly enough, and we won't go into the details as to why, but 6 years later, after the launch of the Affordable Care Act, the small group exchange in Utah no longer exists. So it obviously didn't meet the needs of the marketplace that I think this ICHRA program could address. And I would just say, boy, this is a good topic for the next time, rather than elaborating more here. I think, Kevin, you've covered a lot of the issues very well. Thanks for the question, whoever submitted it. It was great.
Okay, Justin?
And the next question we have is related to the barrier for this being a reimbursement. Are there any proposed solutions that Softheon is thinking about to reduce the administrative burden on this processing?
Yeah, I think, good question. The biggest thing is building tools, and as a payment facilitator at Softheon with PCI compliance and really managing that premium payment experience today for individuals, what we're thinking about is how do we integrate that existing solution that we have for these reimbursements out of whatever account these reimbursements are coming from. So from the Softheon side, we're leveraging some of the tools that we have today as a payment facilitator supporting our issuers and government partners, and we're working on building a solution that will speed up the transaction time and make it as close to real time as possible, where, as I mentioned, some of the potential barriers are if the consumer cannot front these payments, we may have a little bit of a challenge with the adoption. So what we're looking at on our side is really using the tools that we have now to make those financial transactions occur in as close to real time as possible.
Good question, Justin. I was at Softheon Summit a couple of years ago, and I know you talked about, is there a role for, credit cards or debit cards or something like that. I'm sure the solutions will come, and I still have in my mind that picture of your Softheon team that's sitting out there thinking about this. So good question, and I expect great things to be coming.
All right, just looking through the last few questions we have here. If you just give me one moment, please. So we have a clarifying question here, and the question states, please clarify the statement that consumers can choose between the ICHRA. My understanding is that this is true only if the ICHRA does not meet the affordability requirements. If the ICHRA is affordable, the employee cannot get the APTC. Does this remain true?
Yes, that is absolutely correct. And my apologies if that wasn't clear in some of the previous statements. But ultimately, the consumer, when being met with these tools, really what the tool would do is determine the affordability based on the calculation as set forth in the rule. So ultimately, when the consumer goes out and they have their defined contribution from the employer, they will put that through, and ultimately the calculation will determine the quote unquote affordability of the plan in relation to the ICHRA. So only in the event that the ICHRA is deemed to be unaffordable would the consumer have the option to enroll in the APTC. And I think that is something, as further and further adoption occurs, that's something that we'll want to keep a close eye on. And I'm sure there's others that will be looking at that as well to say, is this affordability measure really a true measurement of affordability, or is it putting the consumer in a bad spot and forcing them into something that really is not going to put their best interest at the forefront? So it's a great question. It's a great point. And I think it's something that we'll really want to keep a close eye on, because when we say that we're, the consumer is first, that is not always the case. So we really need to make sure that these affordability measures make sense.
It's a very good question, and there's a number of those clarifying things that we're going to have to dig deeper into. I saw another one around what if the employee chooses an HSA plan? Then the whole thing gets more complicated. So another good question, but thanks for clarifying, Kevin.
Thank you, Ferris and Kevin. So that just looks about to be all of the questions that we have. I'll give it another 30 seconds or so to open the floor to anything else that is remaining.
And if there is a question that comes in, Justin, interrupt me. Part of my closing was to thank Softheon and all of you as attendees in this discussion about ICHRA, how ICHRA can help put consumers first, and how it could improve cost and transparency and consumerism in healthcare. So we really appreciate it. I wanted to close with basically a statement that HCEG's overall mission, it isn't quite as powerful as the Softheon one, but it's guiding healthcare executives through innovation, change, and growth. And we will continue our discussions throughout the coming year, including leading and moderating sessions at other association meetings. During this webinar, I just heard that HIMSS is canceled next week. I have a presentation there, so I'll have to rearrange that. But we're also moderating some sessions at World Healthcare Congress later this month. We'll be involved with AHIP's Institute in June. But the premier opportunity for networking with fellow executives around the country on critical issues in healthcare, the HCEG Top 10 and others, will be our 32nd annual forum, September 21st through 23rd in Boston. And just so you know, last year Softheon invited all 120 participants at the forum to a Yankees-Red Sox game that was taking place during our forum. We don't know what they'll come up with for entertainment in Boston this September, but I do encourage you to register to join us now by going to hceg.org/Boston. You can also email Juliana Ruiz on our website at jr@hceg.org for more information. We can promise you that the annual forum will be a great event, and it will set things up for our 2021 discussions. You can also get information on the industry pulse research that was just announced a couple of weeks ago at the website. So, Justin, any more questions, or are we set?
That about does it.
Okay, well, continue today's conversation via both the HCEG and the Softheon LinkedIn and Twitter handles, and register for the HCEG newsletter, where we each month, every few weeks, update around these topics. And finally, thanks again, Kevin and Justin, for leading this lively discussion. And thanks to each of you on the webinar for the questions and the active participation. Have a great day and best of success with ICHRA.
Thank you, Ferris. Thanks, everybody.
Thank you.